And I want to focus on the emerging treatments for dementia and add some complementary trials to what Sir just told us on lifestyle interventions. So the agenda was to discuss amyloid cascade hypothesis, the points for and the points against it, as well as to give you some stats on lecanemab and donanemab, the newer drugs, and also talk about some other clinically relevant trials. So as we all know from the previous talks that the seminal patient was Auguste Deter, which was described by Dr. Alzheimer, and the key pathology demonstrated there was the amyloid plaques that we can see here in this brown tinge and the core plaque morphology, along with the neurofibrillary tangles that we can see here. So it was described back in the 1950s, and from then onwards, the amyloid cascade hypothesis has been a go-to theory. So we can see that the original hypothesis given in 1992 by J. Hardy has been cited for more than 10,000 times. So it's quite a popular and accepted hypothesis. It all begins with the data that missense mutations and a gain in function, a mutation of the amyloid precursor protein, the presenilin 1 and presenilin 2, increases the amyloid beta 42 production and accumulation and the downstream cascade that we can see here. So the hypothesis has always been that amyloid beta either triggers the cascade or is contributing in some capacity towards it. Also the fact that in Down syndrome, which is trisomy 21, which is the chromosome where a PP protein is located, there is again a gain in function mutation, and that also drives excess amyloid beta 42 deposition in the form of plaques in the brain. So mouse models of Alzheimer's disease, which were developed by genetic mechanisms of adding APP, adding tau mutations, also show an amyloid and tau phenotype, and that also adds credibility to the amyloid cascade hypothesis. And lastly, recently they have also shown that in vitro studies where they take toxic A beta 42 oligomers and infuse it into neuronal culture tissues, that also drives amyloid, that also drives an Alzheimer's like pathophysiology in the petri dish. So this was also been used as evidence to suggest that yes, the amyloid cascade hypothesis might be the place to look for a treatment for Alzheimer's. But then there are a lot of cons to it. One of the major cons is that the Alzheimer's disease profile, either by fluid or by biomarker, the clinical deterioration in Alzheimer's does not actually match that of amyloid deposition in the brain. So the marker that closest mimic it is that of phosphorylation of tau, as well as the neurococ testing possibly when symptoms start manifesting. So there are a lot of points which point against just an amyloid basis for driving these changes. So again, there is lack of association between cortical amyloid deposition and the glucose metabolism in early stages of Alzheimer's disease. Then the prevalence of cerebral amyloid pathology in persons without dementia. So this was the famous NUN study where they showed that even in cognitively normal people aged between 50 to 90 years, about 10 to 44% of them with normal cognition had cerebral amyloid pathology in their brain. So if we are labeling amyloid as being the driver which is causing Alzheimer's disease, why are people who are cognitively normal having amyloid pathology in the brain? Also, the point that there have been so many trials which have failed, about more than 80 trials, all targeting different pathways of the amyloid cascade hypothesis. None of them up till recently have shown any positive benefits in terms of clinical outcomes and improvement in cognition. So what we could be looking at, in essence, is the effects of amyloid, which looks like a phenotype that it's driving the disease, but in nature it might be just a benign phenomenon. So another way to conceptualize what amyloid could be doing is it might just be a trigger that is leading to downstream inflammation, which could be driving synaptic loss, driving the symptom manifestation, or it could be a bystander where it is just innocently found to be associated with Alzheimer's disease when the whole pathophysiologic mechanism could be happening somewhere else in some other systems, like the mitochondria, for example. Or it could be protective in nature. We know from some studies that say the brain has a viral infection like herpes infection. There is an amyloid plaque which covers that kind of infection and prevents the spread of this virus through other parts of the brain. So amyloid could, in sense, also be a protective mechanism in the brain. And in mammalian studies, cheetahs, dogs, cows, and a lot of domesticated mammals all have senile amyloid plaques in their brain as long as they were domesticated and they were autopsied. So amyloid seems to be a normal part of healthy aging as well, perhaps. So what does it mean for Alzheimer's? Yes, Alzheimer's may not be just being caused by the A-beta 42 deposition and the phosphorylation of tau forming the neurofibrillary tangles. It could be much more than that. It could be inflammation, it could be driven by viruses, cardiovascular risk factors, metabolic risk factors, education level, lifestyle factors, genetics, etc. So there is a whole host of factors which could drive this process. So one of my favorite analogies that I've come up with is to describe, say there's a guy, Ramu. Ramu failed his 12th standard exams. So if you can ask the question, why did Ramu fail? Possibilities could be his father didn't pay the right tuition fees, his mother didn't feed him the right food, his brother got him into, say, alcohol addiction, his friends distracted him, he didn't have the internal drive to study. A whole host of factors or a combination of those factors led to the same outcome that Ramu failed. So the brain here, in essence, is failing as an organ to give an output that is relevant cognition and behavior, and the upstream changes which are driving this outcome failure could be multifactorial in nature. So even the genome-wide association studies of Jivas, they point to not just amyloid beta and tau related genes driving associations in Alzheimer's disease, but also something significant that Sir was talking about, the TREM2 mutation which can drive immune modulation in the brain. So there are high evidence for multifactorial causation of the Alzheimer's disease. So this is an image of a diffuse plaque. So diffuse plaque has normal microglia as well as astrocytes, and when they become activated and reactive, that's when you get neuritic plaques. So what's the difference between diffuse and neuritic plaques is the loss of synapses is much more in the neuritic plaques. So it can be considered that there's a seesaw mechanism here. Most senile aging brains will end up having normal amyloid plaque deposition, but there is some kind of a tipping point, could be a microinflammation thing or macroinflammation thing, or could be some resilience factors which are going down, and that leads to the tipping point of conversion of diffuse amyloid plaque into a neuritic amyloid plaque. And that tipping point, once it's reached, leads to the downstream cascade of symptoms. So that brings us to the concept of reserve, that all this time that we have where amyloid starts depositing in the brain before symptom manifestations start, this is the concept of developing cognitive reserve. So you learn more, keep yourself socially stimulated, keep yourself engaged cognitively, exercise, diet, all these factors will ultimately increase that reserve. So although you have the disease process brewing in your brain for decades, you can still push your tipping point to a point which can be modulated. So this is a data from the dominantly inherited Alzheimer's study, where they have been collecting data of presenilin 1 and 2 and APP related families, and they have been tracking the children across time, and in this study they decided to give them disease modifying therapies of gantenerumab and solanezumab, and they tried to see if they could prevent development of the disease in the first place. But the first generation of DMTs didn't do as efficient a job as the current generation of DMTs did, and this trial was in essence a failure, and it was stopped at the end of 3 years. So at 3 years, this trial was stopped because the difference between the ones who did not receive and the ones who did receive was not statistically significant. But in the open label extension studies, it's a very small number. 22 patients of this dominantly inherited Alzheimer's patients did receive gantenerumab for a really long time, about 8.5 years, and towards the end, there was some significant difference between their cognitive outcomes in terms of odds to progression to dementia. It was about 46%. So the question is, did introduction of disease-modifying drugs for a very long time in people who were clinically normal, so they did not have a diagnosis of mild cognitive impairment or dementia, did this change their trajectory and reduce their odds of having dementia? So that is not a high-powered study, is not good evidence, but something to think about. So now, to confirm this hypothesis, there are 2 upcoming trials which are underway. One is called as the AHEAD 345 study, and this involves lecanemab being given to cognitively normal people to prevent their decline. So this is targeting preclinical and early preclinical stages where there is amyloid deposition and some tau deposition as well. The trial is going to run till 2027. So the earliest time that we can have this data with us would be another 2 to 3 years, which may confirm that if we do remove amyloid, maybe we are helping some part of the process. So for example, if a diffuse amyloid plaque is present in the brain and giving this kind of medications is removing the burden of inflammation from the brain, then there may not be enough neuritic plaques to drive synaptic loss and ultimately Alzheimer's clinical phenotype of cognitive impairment. So an equivalent study on the donanemab side is called as Trailblazer ALS 3. Even this is ending somewhere in 2027. And they are also looking at enrolling people who have normal cognition based on amyloid plaques and abnormal tau protein. So those who want to be on the preventive side of things and have a family history could maybe screen and join this. So this is an overarching slide which will talk about in which part of the amyloid processing is the drugs acting. So aducanumab was one of the first drugs to be approved in 2022, and then 2023 it was lecanemab, and 2024 it was donanemab. So donanemab is targeting the fibrils joining together to form an amyloid plaque and is helping better clearing of the amyloid plaque in situ. And so far, I'll show you the PET scan results in terms of centiloids. Donanemab seems to have the best evidence in terms of clearing the amyloid plaques. So coming to an overview of the drugs that we now have with us, aducanumab is out of the market. Lecanemab, the endpoint achieved, the CDR sum of boxes. CDR is clinical dementia rating, in which they assess how severe the dementia has progressed. There has been a 27% reduction in the rate of decline. So that is a very important term to understand, reduction in the rate of decline, which I'll show graphically. Whereas donanemab had a 37% reduction in the rate of decline, and only in those with the low to medium tau group. If you take the overall tau group, then it comes to somewhere around 24%. So if you look at the centiloids on the PET scan, the amyloid PET scan, and the ability of these drugs to clear amyloid from the brain, donanemab seems to have the highest percentage of removal of centiloids. But it comes with a caveat. The caveat I'll explain in just a bit. So as lecanemab cleared the amyloid from the brain, it achieved about a 27% reduction in the rate of decline. So this kind of reduction is what was statistically significant, and this is what got its approval from US FDA to be approved as a therapy for Alzheimer's disease, but in the earlier stages of the disease and not in the later stages. The same with donanemab. So the donanemab data in the low to medium tau population, the decline was about 37%. And in those with overall population, it was about 22% slowing versus the placebo. So here as well, you can see that donanemab did clear amyloid from the brain, and at the same time, it also improved cognitive functions. So what is the caveat? The caveat is when you give these drugs, as they're removing amyloid from the blood vessels and the brain, it also leads to some side effects which can be seen on the radiograph. So the side effects are called as amyloid-related imaging abnormalities, or ARIA. ARIA-E is the one where you have edema, and H is the one where you have hemorrhage. So I'll show you some examples. So this is an MRI flare, which, yes, so clearance of the amyloid in the vessels would cause the hemorrhagic conversions. So this is the 16th week of receiving lecanemab and then the 24th week, and we can see that there are these flare hyperintensities in the left occipital lobe, and that is suggestive of ARIA-E, or the ARIA edema. So similarly here in the right frontal lobe, we can see that there is hemosiderosis seen on the GRE, or the gradient echo scans of the MRI, which are showing deposition of blood stains in between the cortex in the occipital lobe on the right side, in the parietal lobe on the right side, as well as the frontoinsular cortex. You can see this microhemorrhages, multiple punctate ones, as well as the hemosiderin patch in the frontal lobe on the left side. So ARIA-E, that is the edema part of the ARIA, what symptoms does it cause? So the symptoms could be non-specific, could be confusion, could be headache, could be disorientation, could be word finding difficulties, and these symptoms occurred in about 2.8% of patients ApoE epsilon 4 carriers versus lecanemab, which was 10% and 7%. So what has donanemab done to help reduce the incidence of ARIA? So donanemab has conducted another trial and have shown that in a modified titration regimen, where in the first month you give a lower dose of 350 milligrams IV, followed by skipping a dose, followed by 700, skipping a dose, 1050, skipping a dose, and then reaching the full dose. That way, they have shown that the incidence of ARIA becomes statistically less. So this outcome is statistically significant, and the incidence of ARIA did decline after adding in the modified titration. So the cons of these new drugs, first, the IV infusion part. So lecanemab has to be given twice a month, or it's a fortnightly regimen intravenously, and donanemab is a once monthly infusion. The price for lecanemab set by SI and Biogen is about $26,000 per year, and that was without insurance coverage as per the paper. And the price for donanemab set by Eli Lilly was about $32,000 per year without insurance coverage. And this cost does not cover the cost of hospitalization, the IV infusions, the MRI scans that need to be done to look for ARIA. And the recommendation, the US FDA recommendation for lecanemab is to do serial MRIs on the 5th, 7th, and 14th doses. For donanemab, it's 2nd, 3rd, 4th, and 7th doses. So how do we understand this 27% reduction or the rate of reduction in progression of the disease? Another way to look at it is in the terms of time saved. So the same data was analyzed differently, and then they showed that the time difference between the placebo and people receiving lecanemab, this time or meaningful gain at function at the end of 18 months was 5.3 months. So the patients who received active drug, they had an extended meaningful quality of life of about 5.3 months. So the question to ask is it worth risking ARIA-E, ARIA-H, as well as having IV infusions every month for the outcome benefit of 5.3 months? So the answer would be individualized, and that kind of counseling needs to be done before a patient receives this medication. So looking at it from another angle, just the quality of life results from the lecanemab Clarity AD trial. Here we can see that the quality of life index, which was scored by the person themselves, they suggested that they experienced a 56% reduction in the symptoms that they presented with, versus quality of life rated by the caregiver, which was about 23% less decline. So to end with what's new, lecanemab, the injectable subcutaneous version, has been approved recently, but only for continuation. Once you have given it for 18 months and the ARIA incidences have been sorted, then recently it has been approved with a subcutaneous injection. So there is hope that if the subcutaneous injections become more popular, then the IV infusions can be done away with. So the future is a little hopeful in terms of newer molecules which can be approved, and the quality of plaque clearance by reducing amyloid-related imaging abnormalities may also improve in the future. So I think I'll skip this. Appropriate use recommendations can be scanned and read. Right now, India has not approved these drugs yet, so I'm not going to be discussing this. What I'm more happy to discuss would be some new trials. Yeah, I'll wind up. So I'll just talk about some trials which are related to what Joy sir was saying. So Joy sir talked to us about lifestyle interventions and how they can help prevent rate of decline. What I'm going to ask the question is, what about compliance? We all give advice of lifestyle changes to our patients, but how many patients are actually compliant with this advice that we give them? So this is one of the seminal studies, the FINGER study, the Finnish geriatric intervention study to prevent cognitive impairment and disability. Results, I'll jump to the results. So the volume of patient is significant, 1,000 plus, age 60 to 77, all having an increased risk of dementia. And if you look at the results, with structured intervention, with exercise, diet, you have stimulation, cognitive stimulation, and social interaction, 4 parameters, there is significant improvement, 25% greater improvement in the overall cognition, 83% with executive functioning, 40% with complex memory tasks, and 150% improving in processing speed. So yes, all lifestyle advices does work, but if it is given in a structured, systematic way with supports, then it is better outcomes and there is better compliance for it. And the same thing has been replicated recently in the US pointer study. I'll skip this, but with physical exercise, health monitoring, nutrition, and cognitive exercise, there has been positive outcomes. I think I'll stop with that. And I hope that the future is hopeful.